taken the annual Meneely Tour speakers. We've been fortunate, as you look back through the years, to have really some of the giants of pulmonary medicine, people whose names you recognize anywhere you go in the United States. And this year is no exception to that. Dr. James Crapo has joined us from National Jewish, as you see. It's been fun chatting with him. I mean, his career has been one where he recognized opportunity. He came up with very practical ways to pursue that opportunity. He started off going through medical school, and because of a stint working with NIH, got involved in research and apparently loved it because he's continued to do it to this day. He ended up working out of North Carolina for the National Institute of Health, and then went on to complete his undergrad at Duke. Shortly after finishing his fellowship, within about 4 years, if my math is still correct, he was chief of the section there and built a world-class division. He had, as I said last night, I started counting his publications. I got tired of counting publications, so instead I reverted to counting pages of publications. And he had more than 30 pages worth of publications. Has served on all of the boards that you'd expect and study sections and the like. But really, what's remarkable to me is how his career's evolved. He began really looking at cellular biology, and then later in life made a really remarkable transition from cellular biology and really lab-based science to human subjects-based science. He's now very interested in COPD and the pathogenic mechanisms by which we get there. He's one of the co-principal investigators on COPD gene, which is a cohort study of patients who are smokers, so at risk for COPD, and looking at what sort of differentiates the people who develop COPD from those that don't. And he will expand on that, and as a result, I give you Dr. Crapo.
Well, thank you very much. It's really an honor to be here, and I thank you for that generous introduction. And I consider it a privilege to share some of the work and ideas that I've had to you, and I'll try to make it very practical at the same time. So I want to talk about COPD, and I consider this the greatest epidemic of disease in America, and I'll explain that to you in just a minute. And one of the biggest poorly addressed challenges that we face in medicine. The normal lung looks like this. It has about 500 million alveoli. And Evil Bible characterized these 50, 60 years ago, saying that the surface area of these alveoli are as big as the surface area of a tennis court and have about 1 cup of blood in it, which is where the oxygenation and loss of CO2 takes place, and is covered by a very, very thin membrane that's about a half micron thick in most places. Far thinner than the thinnest air mail station area you've ever seen. A very delicate structure, and yet its incredible thing is that it functions so well over a lifespan of 70, 80, 90 years among most people. That's compared to an emphysematous lung, in which massive destruction takes place. I'm going to talk about how and why that occurs from these dried lungs. Now, we know the cause. The primary cause for it is air pollution or smoking, and smoking being by far and away the dominant environmental cause, with literally hundreds of thousands of toxic materials, particles, oxidants in it. And the amazing thing is that humans voluntarily do this to create, I can't think of an animal experiment where I give animals this kind of a dose. Humans voluntarily do it 20 times a day with a pack of cigarettes. Van Gogh, people like have recognized this for hundreds of years. This is my favorite painting from the Van Gogh Museum near Amsterdam. Now, interestingly, if you look at the incidence of the disease, and we're sitting here very close to the epicenter of where it's the highest concentration. You probably all know that. You certainly see a substantial amount of it here in Louisiana. And I spent, as I said, about 25 years of my career in North Carolina. This is the graph that I really find interesting. It shows that among some of the common causes of death, if you look, and this is adjusted to show the rates. This is when I went to medical school, and it's about 18 years old, but in fact the same concepts are taking place. Every major disease has gone down in frequency, a 59% decrease over this period in coronary artery disease. Stroke is down, other cardiovascular diseases, all causes is slightly down, but COPD has been increasing. It's the one large major disease in the United States that's been increasing during my entire medical career. This has tailed off a little bit in men, but it's actually continuing to increase through today in women. They were forcing to start a little bit later, and they're just catching up to us. Now, if you look at the global causes of mortality in the world, the major causes were heart disease and stroke. But it's interesting that if you look at this, COPD has increased over the past, well, predicted, this is where it's going to go in 2020, so that's a 30-year span. But from 6th to 3rd, and its companion lung cancer has gone from 10th to 5th. And as I say, they're the only ones that are going up. Why and how and what can we do about it is the question I want to ask. But recognize this as a true disease epidemic that's under control. Now, as I said, when I went to medical school during this period right here, this was a classic picture of COPD. A big chest with low flat diaphragms, hyperlucency across both lungs, and a classic central lobular upper lobe predominant emphysema. Today, a lot of changes have occurred. And I want to go over some of those and talk about them, but CT has been one of the tremendous advances. And you can see on this CT that was published in New England Journal of Medicine about 10 years ago, you can see the areas of hyperlucency, of emphysema. You can see the lung cancer that's the cause for this. If you look, actually, if you could go up and down, you'd begin to see coronary artery calcifications, and you'd see aortic or thoracic calcifications commonly. If you do density on the spine, you'll see osteoporosis. You'll see loss of muscle. You'll see loss of muscle mass in the structure here, and you can even see in the right-hand pocket of that patient the primary cause. Now, well, we keep going in the right direction. So, about 10 years ago, I helped start a study, and I really asked myself how I could use the last part of my career to really make a difference in my field, and the biggest disease is COPD. So I elected to try to coordinate a large amount of efforts to really focus on it and see if we could make some difference on that. We started a project called COPD Gene, the name we gave it. And our goal was to try to figure out the differences, why we have one patient who looks like this, the classic Netter drawing, and yet we have additional patients that look like this. And I found that in the Daily Mail at the same time we started the study. And why? Why does one smoker develop rapidly progressive lung disease and another one smokes for and has very little disease? And so we organized this project, and actually 21 different medical centers across the United States came together, and these are where they're located, and we built a cohort. Now the cohort that we built is a total of a little over 10,000 subjects, with about a little over 40% of them being controls. And the controls were, we required every single person in the cohort to smoker. And we required you smoke 10-pack years to be in the cohort. I'll show you what actually happened in terms of smoking, because very few people smoke 10-pack years. But about 43% were these controls who theoretically had no disease. About 2,000 of them were what I'm going to call Gold 1 and U, and I'll explain that. And about just a little under 4,000 had progressive steps of COPD termed Gold 2, 3, and 4 by the international criteria called GOLD, GOLD meaning Global Obstructive Lung Disease. And I'll explain that in a second. Here. So the way you basically classically evaluate COPD is to look at the ratio of FEV1 to FVC, and if that, a normal is about 0.7. So patients below 0.7 on this ratio, all those patients are considered to have COPD, and the ones above this curve are considered not to have COPD. That's standard GOLD criteria, and if you grade as the FEV1 drops, this is FEV1 on the x-axis. As the FEV1 drops below, if it's above 80%, they're considered very early or Gold 1. If it's between 50 and 80%, they're gold 2, and between 30 and 50% is gold 3, and below 30 is gold 4. So this is all 10,000 subjects in our cohort shown on this, where they are. Now, what we discovered very early on is essentially within days of starting the study, people came in and said, "I've got a patient with a normal FEV1 FVC ratio, but a low FEV1." So they're in this quadrant. So they're low on the FEV1, but normal in the ratio. What do I do with them? It turns out that that's not in the gold criteria. We called it gold U or undefined, and said, keep them in the cohort. Let's see what happens to them. Everyone thought they were just fat. They were overweight, and therefore they had low lung volume. But it turns out that only explains about 10 or 15% of them. And we have eventually come on to define this in more detail, and we now call it a preserved ratio with obstruction, and the nickname we've given it is PRISM. So having said that, I want to explain to you a little bit more about these various cohorts here. If I look at smoking history among this cohort, this is a gold U or PRISM group that I talked about. But it's interesting that and this is the control subjects that have smoking, but who theoretically do not have obstruction. Notice that the average smoking incidence is over 30 and exceeds even 40 pack years, increasing to a max close to 50 pack years in the gold 3/4s. So it turns out that people start smoking in their teens. If they are going to stop, they usually stop before they get to 10 pack years. Yet once they smoke 10 pack years, there's a powerful addiction component that goes with that. And in fact, the nicotine addiction genes are the most dominant gene we found among the group. But they rarely stop after 10 pack years until something late in life causes them to stop. Commonly a heart attack. I'm sure you could all, in your own experience, tell me what that is. But it's adverse events when they're in their 40s, 50s, and 60s cause people to stop smoking. Now, we found that by looking at current smokers. Remember, everybody was a smoker in the cohort. But if you look at when they're 45 years old, 80% are smokers. By the time they're 70 years old, it's only about 20% are smokers. So they're stopping during this period of life right here. And I want to come back to this because that means that, in fact, when I started my career, smoking was considered just a socially bad disease. It's your own fault. You shouldn't have smoked. Now stop. And that was basically how was the attitude. But in the 1990s, you remember, we finally started to realize that the patients who smoked were a victim, not a perpetrator. And you see all the heads of the tobacco companies before Congress swearing that in that famous picture that we're talking about, the attitudes changed in the 90s. And we began to realize that there was a disease here and that the people who stopped smoking have done their part of the job. They have done what they can to change their health. And as a medical community, we've failed to help them, and I'll talk about that going forward. We've failed to do something to help them prevent progression of their disease. Let me go on to talk about the distribution of COPD. If you look at the COPD, but diagnosed as gold 2 to 4 in red. So this is considered as COPD. There's about a 15% incidence of it at age 45. This is gold 1, which would be, or the U, the mild, let's say the mild or the beginning step. And the blue is theoretically people without COPD. But notice that COPD forms during the 50s and 60s and reaches about anywhere, depending on how you take these curves here, but it reaches someplace between 25 and 35%. 65% of patients have COPD by the time they're 70, 75 years old. This is to remind us to think that if you're going to stop the disease, where would you treat it? I think you treat it back here. Where do you treat it today? This is what you treat. And I think this is one of the big errors of medicine, is that we have not figured out how to treat it, and we're treating too little, too late. And we're missing the beginning of the disease. If you want to stop that disease right there, you definitely should go back here and stop it. And so let's talk about how we can do that and what it's going to take to accomplish that. Now, how many people are at risk for it? In the U.S. population, People diagnosed with COPD is about 15 million. But if you take heavy smoking history, like I'm giving here, there's at least 50 million people in our population over age 45 who are at risk for this. That are in and I've got 10,000 of them in this cohort. But that means there's about 35 million people with either at risk for it or undiagnosed COPD. So let's look at that population. Now, the first thing I want to point out, and this actually came from a study at the National Cancer Institute in 2008, but the graph I'm showing you was published in the New York Times. So it's trying to make it, and the size of the circle tells you it's proportional to the number of deaths per 1,000 population over 10 years. And it's broken into non-smokers, former smokers, and current smokers. And this is male on top and female on the bottom. Now, what I'm trying to show you, and the causes of death among non-smokers, heart disease, and then stroke dominate, and then a variety of cancers dominate in non-smokers for both men and women. For smokers, heart disease is still the most common cause of death, but now lung cancer is second, and COPD is third. And a similar thing is roughly the same, but very similar for women. Look what happens to this when you talk about former smokers. And remember, when former smokers are largely heavy smokers that quit in their 40s, 50s, 60s. In men, the primary disease is heart disease, and it doesn't really change a whole lot. Lung cancer decreases in significance. We compare those circles to these right here. So lung cancer decreases if you stop smoking. But COPD does not decrease. And the same thing's true down here for women. There's no change in the death rate. What I'm trying to tell you is if you have smoked 40 or 50 pack years and you stop when you're 50 years old, if you're one of the at-risk people who will develop COPD, it's going to keep going. And when you're 70 years old, you're going to be taking oxygen and medications and be a classic COPD patient. And that's really important because stopping is not sufficient once you've activated the pathways. And I'll talk a little bit about what those pathways are, but it's very important to understand that stopping smoking is the first thing you do, but it is not by itself sufficient to prevent COPD. So let's talk about early diagnosis for a minute. Do smokers without obstruction, now these are people with a normal FEV1 when they come in, and I want to ask, are they really normal? Remember, we have over 4,000 of them in the cohort, and we followed them now in the COPD gene cohort, we brought them in. At these 21 medical centers, they have chest CT, both inspiratory and expiratory. They have detailed questionnaires. They have a physical exam. They get spirometry, and we get blood drawn for genetics and things like that. And then we follow them up again every 6 months by questionnaire, and we follow them up every 5 years with a repeat visit and repeat CT scan. So our question is, are they normal or not? And I'm going to look at various things like dyspnea, exercise capacity, CT evidence of emphysema or gas trapping, exacerbations, comorbidities. Now, it turns out that if you look at MMRC dyspnea score, and dyspnea score of 2 means that you have very limited capacity to walk. It's a substantial impairment. Of the gold 0 subjects who have no, for example, first of all, just gold 2 who definitely have COPD, about 50 to 60% of them have a dyspnea score of 2. But it's about 15% among patients in gold 0. So they have dyspnea. And remember that there's a lot more of these than there are of these. There's probably something like close to 5 or 10 times more of people in this category than in that category. So it means if you're talking about dyspnea in general, it's actually more common down here than it is up there in terms of the population. If I look at gas trapping and emphysema on chest CT, now this is kind of complicated, but this is the amount of emphysema going up. And if you take 5%, and I take 5% as a cutoff because when you're measuring what we call emphysema on a chest CT, there's confluence of airways and branching patterns such that you get some empty spaces in the lung naturally. And it's the natural amount of empty space in the lung at this level is about someplace between 3 and 5%. So a person with more than 5% empty space on the CT would have evidence of emphysema, for sure. And if you look at this, about 10% of the people, 3 plus 7%, are above this blue line. And in fact, some of them are up to as much as 20% of their lung as a whole. So you can have a fair amount of emphysema and still be in this so-called normal group. If you go the other direction, this is gas trapping, and we consider by looking at a normal population that up to about 15% gas trapping is within the normal range. But if you take this whole population out here, 7 plus 18%, or 25% of the people have significant gas trapping. And that can be as high as 70% of the lung is gas trapping. And what I mean by that is we look at an expiratory CT, and we look at whether the units are ventilating. So we look at the density of the lung and see it's supposed to go down as you breathe out. But in this case, if you gas trap, the density of the lung will not go down in that region, and that's called gas trapping. So I'm just trying to point out that people that are so-called normal have a significant amount of emphysema and gas trapping on chest CT. Now, I'm pushing the wrong buttons. On CT, that can look like this. You can see the small little spaces of central lobular emphysema, holes in the lung. You can have more, this is just a prettier picture of some of it showing the size of the bleb here. Color-coded by lobe shows you where you have increased amounts of emphysema spread throughout the lung. This is a gold zero subject, just to illustrate that there is significant emphysema in these patients. If I look at the people who haven't smoked and look at the number of them that have either emphysema, which is shown in red here, or just airway disease, and I call it bronchial airway disease, which is shown as a thickened airway wall. It's a very tiny fraction of a total, just a few percent. It would be non-smoking related early airway disease. If I look at the gold zero subjects, though, that are thought to be normal, you can see that about a little less than a quarter of them have evidence of various types of emphysema, and about 15% have significant airway disease on CT. So I then asked the question, I'm looking for what I'm going to call sick smokers, people who are said to be normal, but who have either a Bode score greater than 1, who have a limited 6-minute walk, have a dyspnea score equal to or greater than 2, have a quality of life score greater than 28, who have evidence of cough and sputum or bronchitis, or who have evidence of emphysema by CT, or evidence of gas trapping by CT, or a history of more than one or more exacerbations. And I asked that question, how many people of my so-called normal 50 or 60-year-olds look like that? And the answer was pretty amazing. If they had one or more of those signs, they're in red. If they didn't have it, they're in blue. You can see that even at age 45, that about 60% of the people who are thought to be normal have one of these symptoms. And it reaches close to 75 or 80% by the time they're 75 years old. In other words, they're not normal, and they're not being treated. And you bring them in, you look at them, they say they're still active, they're working, but we don't really recognize the impairments that they have, nor do we make any attempt to treat it. Now, one of the questions, we say they're not obstructed. So we're measuring FEV1. This is the curve of FEV1% predicted in those gold zero subjects, 4,000 plus of them. It looks like that. If I measure that, and this is all normal, this is above, because they're defined as being normal, they're greater than 80% are predicted. So they're, by population statistics, these are normal ability to breathe. But ask yourself, is that normal? And what I want to point out that if you do this in non-smokers, the curve looks like this. It goes up like that and peaks here and goes down. It peaks at 100% predicted. This entire group is shifted about 10% to the left. It means that they are individually obstructed. It just hasn't exceeded a population normal. And if you had been, a person, for example, could start out at 100, an individual might be 120% of predicted, and they can lose 40% of their lung volume and go down to this curve and still be considered normal by this population metric. That's what we're doing. If you want to know if an individual who's smoking is becoming obstructed, you have to have serial measurements on that individual and not necessarily a population statistic. So I would argue that these people are obstructed. They just haven't exceeded the population standard for it. And they have dyspnea, they have all the symptoms of COPD. Should they be diagnosed as COPD? I think they should, but none of our national or international criteria make that diagnosis today. But we need to recognize these people are at least 6 smokers and deserve understanding and treatment and prevention of progression. Okay, so now, I want to go on and say, how do we define people who are at risk of going forward? Because even though I've told you that these people are at risk, not all of them will progress. So how can we figure out which ones are at greatest risk when we put our effort there to treat them? Well, we've done it many ways, but the best one that I've seen happen come out over the last several years is an analysis called principal components analysis. Now what this does is that we take a lot of variables, all of our CT variables, our pulmonary function variables, and we assign a factor loading score to each one of these, and then they use a complex computer-based algorithms called principal components analysis to look at these to see how they correlate for each person. So I'll try to illustrate it. These are the things that we put into for the what we call one axis an emphysema axis. It's just the name we gave it. But these are all the variables in CT and PFT that we put into the equation. And you'll notice that if they have a low value for lung density on both on inspiratory scans, they have a very high correlation, like a 90+% correlation with emphysema. And if they have gas trapping, there's a good correlation. On the other hand, if they have thickness of their airway walls, which is indicated by this number right here, or let's say airway wall percent, it's a pretty low correlation. And they have a fairly good correlation with pulmonary function. So these people have emphysema, but not a lot of airway disease, as you can see by this parameter. And in contrast, another axis that showed up was an airway axis. And here, the correlation with airway wall thickening is quite high. It's above 0.5. And the correlation with inspiratory, let's say emphysema, this number right here, is very, very low. So that's how this was done. It's all agnostic, and it's done by just feeding the parameters in and then doing a complex analysis to see how patients correlate. And every single patient has a score along both of these axes based on their function. What was fascinating was we put that onto this graph that I've already shown you, and this is what it looks like. Notice that the red are the people that are in the highest quintile, the highest 20% of those for airway disease, airway wall, so let's say airway disease. So that's the airway disease axis is in red. The emphysema axis is in blue, and if they have both, they're in yellow. And amazing, it separates. You can see that the red the airway disease tends to start up in the gold U or prism group and go down with a better ratio, but a lower FEV1. So they fall on this side of the curve. Now we looked at mortality in this group, and it was really incredible what happened. If you look at mortality on people on the emphysema axis, the top 20% have about a 2 to 3-fold increased mortality if they have emphysema on that group. If they had airway disease, that top quintile had between 40 and almost 80% increased mortality. I would bet that most of you don't consider airway inflammation, airway disease as a dominant factor in COPD. We think of it as emphysema. But this is telling you that there's another major parameter that drives the disease. So if I look at mortality, if they had none of these, they have a 5% mortality over the period of observation. If they have emphysema, high-risk emphysema axis, they're 10% mortality. If they have the high-risk airway disease axis, 18% mortality. And if they have both, 34%. Now, we looked to see what the cause of mortality was, and the cause was all over the place. Red is pulmonary, which dominates down here, but a lot of these diseases occurred for other things like cardiovascular disease or cancer. And you can see that cardiovascular disease dominates up in this area. So there's all-cause mortality, and what I'm coming back to on this is that COPD is a multi-system disease. They're not necessarily dying of lung disease, because they have involvement of multiple other organs. And I'll come back to that a little bit. But I want to say that these axes predict more than mortality. This is shortness of breath or dyspnea. And you can see that there's an increased dyspnea in the emphysema axis in blue, in the airway disease axis in red, and markedly increased if it's both. If I look at how far they can walk, and that's been recently published in an article showing that the walk distance is one of the best parameters for finding these patients. But this is how many, this is distance in meters in 6-minute walking. And you can see that that drops if you have the emphysema axis. It drops further with the airway axis and markedly drops if you have both. If you look at quality of life, measured by SGRQ, the same parameter. Poor quality of life, which is a higher number for the emphysema axis, markedly worse with the airway axis, and even worse with both. Cardiovascular disease, I've talked about that being related. The cardiovascular disease being measured by us is we're looking at the CT, which we had, and we're looking at the presence of coronary artery calcium and thoracic, coronary calcium and aortic calcium. And the 13% without being on the disease axis, but that increases to 16% with emphysema, high risk, 26% with airway disease, high risk, and both are at 20%. This is probably lower because you're getting a lot of pulmonary deaths down here, removing the population from the measurement. So those are ways to really begin to look to see who's at high risk. And you can actually, with a CT and a PFT, you can now put any single patient quickly on those axes and see where they fall. But the other thing to recognize is that COPD is not a single disease. It's a syndrome. And we tend to think of it as a single disease, and we treat it as one, but that's grossly inappropriate. There are multiple types of emphysema. We've recently published a paper with the Fleischer Society defining CT basis for 10 different types of COPD. The emphysema predominant types break into central-lobular, pan-lobular, and paraseptal types of different gradations. I don't have time to go into all of these, but the central-lobular emphysema breaks down around the center of the small airways in the lung. And this is a classic picture of what it looks like. It slowly expands out. The ones I showed you at the beginning of the talk were central-lobular. This is paraseptal emphysema. You only have to look at it for a second to see it's not the same disease. Peripheral, around the lobules, it has a fairly substantial mortality if you're with it. It's also associated with a lot of central-lobular emphysema here. But this pattern here is genetically different, has different genetic signals, and it can occur early, and it's a predictor of progressive lung disease. I suspect that most of you are not diagnosing this disease. If I look at the frequency of emphysema versus airway disease, if I look at the early stages of the, let's say, gold 0, those are smokers without population-based airflow obstruction, and the gold U and 1, you see that the major disease is really airway as opposed to emphysema. And even when you get to gold 2, it's about half and half. And once you get to the advanced gold stages, it's predominantly emphysema predominates. But most of the patients are up here. So that's important. If I look if I take all the patients with emphysema out and just look at who has airway disease. Now, they can be either large airway disease at the bronchial level or small airway disease. The larger airway disease you can see because you can see the thickened airways. The smaller airways are below the ability to recognize them. But it's the most common form of COPD is destruction of the small airways. And what you see is you might see micronodular opacities, or you can see gas trapping on expiratory CT, or you may see obstruction where there's no emphysema to explain it. So how often does that occur? This is a picture of the thickening of the airway walls in a patient with marked airway wall, big airway. These are bronchia, major bronchi in the first 3, 4, 5, 6 generations. But if I look at if I take all these together and say how many of our patients have airway predominant disease, it's in the milder forms of the disease, it's between 35 to 65% of the patients have airway predominant disease. And if I put that together in this graph, and this is the point I'm trying to make, is that emphysema predominant disease is one that occurs later in the disease like this. This is where we're treating it. But the early disease is down here in airway. So remember I asked the question, are you going to treat early? What do you treat early? I think the disease that you look for early and you treat is airway inflammation. It's an inflammatory process. And that's not part of any current dogma for how you treat COPD. So let's look at airway inflammation as a source of this. It's been known for a long time that it's a big part of the disease. This is from 1969. Ann Wilcock and Peter Macklin published that the peripheral airways may therefore be regarded as a quiet zone within the lung, in that obstruction within them causes little abnormality in tests designed to specifically detect it until the obstruction becomes far advanced. So I'm not telling you something brand new. Jerry Mead said it's the lung's quiet zone. Small airways are a silent zone in the lung where disease accumulates for years without detection. That was 1970. The first author was Dr. McDonald, but this is Jim Hogg's lab work. Actually started to measure the number of small airways in the lung on some very sophisticated pathology. And he's published this a few years ago. If they look at control subjects that are non-smokers, the average number of terminal bronchioles in the lung is about 22,000. That's very small final airways. If you look at patients with central lobular emphysema, that 90% of those are gone. There's only about 2,400 of them. And only about 6,000 left in panlobular emphysema. What we're trying to say at the early part of this disease is destruction of the small airways. It literally prunes the airways back during the so-called silent phase when we don't treat the patients. So what's going on? This is a cast of the lung right here. A normal human lung, showing the detail. And at the very peripheral down here, there's 22,000 small airways like that. What happens in COPD is you prune this off during the early parts of the disease when we say they're so-called normal. And remember, our FEV1 is only measuring the airflow obstruction of the larger airways. So you're not seeing the small airway destruction. So this is just an example of a patient with mild emphysema. And as I'm trying to show you from one of our cases what the airway structure looks like in let's say zero gold U. This patient would be a gold U subject with about 5% emphysema shown by these circles here. But this is an extreme case of pruning. This is a gold 4 patient, massive obstruction, really, really, really tight obstruction, but no emphysema whatsoever. And look at the pruning of those airways. They've lost 90% of their airways. You'd recognize this patient, but you wouldn't recognize any emphysema. So I'm trying to talk about understanding that there's a huge airway disease component. That's an extreme case. Next, I want to talk just briefly about comorbidities, because this is not a single disease. It's a multi-system disease. And I'm not going to go through all the details of it, but the concept of the exposures to environmental biomass or cigarette smoke, genetic factors combined together to lead to a systemic inflammation that goes past the lung. And that affects the musculoskeletal system with cachexia and weakness. It affects the cardiovascular system, multiple metabolic diseases, including diabetes and metabolic syndrome, multiple bone diseases, primarily osteoporosis, and psychological diseases like depression. These are just a small list of the total. But let me show you its impact. Graham Barr recently published a list of the comorbidities found in patients with COPD, and you can see that 50-some-odd% or more have these various diseases of the heart, depression, cataracts, osteoporosis, sleep apnea, diabetes. If you're going to treat this disease, you've got to treat these, and you've got to recognize them early. They have an impact. Lung cancer is high. About 7 to 10% of deaths occur to lung cancer. If you have COPD, you are at 3 to 4-fold increasing risk of having lung cancer compared to an equivalent smoker who does not have COPD. The FEV1 is your greatest single predictor in a smoker if you're going to get lung cancer. They're related. People have the systemic inflammation that affects cancer, and it probably affects it in more than just the lung. But that's important. Cardiovascular disease is more common than COPD. If you take the controls non-smokers, there's a markedly increased risk of arrhythmia, angina, MI, congestive heart failure, and stroke in patients with COPD. In fact, a point I'd like to make is which is the better predictor of heart disease? Cholesterol, hypertension, or FEV1? The answer is FEV1. if you have a low FEV1, your risk of having heart disease is about 3 to 4 times higher than without it. And neither cholesterol nor hypertension reach that level of risk. Osteoporosis, again, I've talked about it multiple times. Is this as severity of airflow obstruction, the risk of osteoporosis goes up in both men and women. And of course, that's a major cause of morbidity and mortality. As you probably know, falling and breaking a hip is a major cause of mortality in the elderly at the same time you develop COPD. So we're causing about life-threatening illnesses by having this happen. And that's related to the systemic effects of COPD. If you look at the effect of comorbidity on your MMRC, which is your dyspnea score, you'll notice that people with comorbidities have increasing MMRC scores, which means they're more dyspneic. And it's an argument for treating the underlying diseases as well as the lung disease. Or if you look at the impact of comorbidity on how far you can walk, there's decreased 6-minute walk associated with virtually all of the comorbidities. So I'm just trying to argue this is a multi-system disease. You don't just take care of one part of it. This is quality of life. Quality of life is worse, higher score, in patients with comorbidities compared to in association with this disease. So I'm going to end with a few minutes talk about treatment. So I've talked about process. I wish I had the total answers in treatment. I would tell you our problem in treatment is that this is the loss of FEV1 over time classically in a patient. And this is what we do about it. As they develop increasing symptoms, the first thing we do is tell them to stop smoking. We may start vaccinating them for pneumococcal vaccine. And late in the disease, we start bronchodilators. We may add steroids. You put them in pulmonary rehab. We put them on oxygen. We talk about surgery. You're talking about very late. This is what I call too little, too late, and focused on palliation. But this is where the disease occurs, right here, and this is where we need to begin to intervene. Now, same concept. This is where we're treating a disease. This is where we should be treating it if we're going to prevent it. Now, how do we prevent it? I wish I had the answer. I want to just make the comment that I can't tell you how to prevent it. I can tell you that I take a statin because I have high lipids. There's no proof that's going to make my life any longer. But I've accepted the concept and I'm taking it. Okay? Now, if I were a smoker and 50 years old and I had any of these signs and symptoms I've been giving you, I should be taking something to control that inflammation. I don't know for sure what it is. It's going to be some type of powerful anti-inflammatory or cocktail of them. Now that we can define it, we need to figure out what that is. But you need to be thinking about what you can, I'll talk for a few minutes about what you can do about these patients. But there's also a lot of research that has to be done to figure out the proper, our so-called pulmonary statin, if we can ever figure that out. One thing you can do is you can put in the COPD self-assessment test. And I've given you, there's copies of it on a little handout I've put here for you. But it's a very simple measurement of common things like your cough, sputum production, chest discomfort, how far you can walk. That is a very powerful indicator of whether or not our disease is worsening. And a change in the SCAT score of 2 or more suggests a possible change in health status. This is something you can have your patients fill out in the office while they're waiting to see you and put a CAT score in your record just like you put their blood pressure in. And it would warn you when you've got to activate and do something to a patient in advance of when their real symptoms occur. So I would just argue this is it's been well standardized, and it's very easy, it's cheap, and it's something that we ought to be doing regularly on any patient. Anybody that's a smoker or former smoker that's 50 years old or more, you should be doing this on every visit. I put on the table, and there's still a few left here, this is a small pocket consultant that's put out by this is brand new, it came out this week from the COPD Foundation. About 5 or 6 of us helped write this. It's a little more aggressive than is the gold guidelines, but it basically stays with evidence-based medicine, and it summarizes the drugs and the basic approaches you should use to treat the various aspects of the disease, and it gives you the scoring systems for the CAT and the scoring systems for the dyspnea, and talks about the asthma overlap syndrome. I just advise this a great pocket little guide, just 2, 3. You can have, and if you need more of them, you can get them from the COPD Foundation. They're free. But I would encourage you to use this. It's the more standard therapy. Now, what I'm pushing is even more than this. I'm pushing to think about the earlier patient where we really don't know how to treat them, but they're smokers at risk, and they need to have careful attention to inflammation. They need to have careful attention to comorbidities. They need to be careful to stop smoking, avoid environmental exposures, and we need more research to tell us exactly which drug could actually intervene to evolve it. But there's a lot of care that can be done. It's not part of standard bases for care. What are my bottom lines today? I just wrote this last night and say, what are my take-home questions from what I've learned from working on this cohort for 10 years? Well, one is that we should diagnose this disease early, or and the history of smoking creates high risk, but stopping smoking doesn't stop risk of progression of the disease. Look for the treatments, which are what this guideline says here is treat by symptom. You don't have to treat by FEV1. If they've got symptoms, treat them. The long-term goal, which we're not ready to tell you what it is yet, is going to be an effective airway anti-inflammatory therapy. Because airway inflammation is a very predominant part of the early disease, and you can find that by looking at airway wall thickening on CT or measuring gas trapping or mosaic pattern on CT. Early onset of emphysema. Now, for high-risk patients, if you have airway disease plus emphysema, those were the very highest risk patients. You want to look for the evidence of airway wall thickening early in the patient, and you want to look for, if you start seeing little evidence of emphysema early, that means they've got both, and they're the very highest risk for progression. So those are things you can learn from CT today. Diffuse or lower lobe emphysema is particularly associated with high risk of progression. Advanced upper lobe central lobular emphysema has a very high risk of progression. And this is a multi-system disease that can be treated and in which you need to think about the comorbidities and treat them aggressively. One last word is that I know you're starting a lung cancer screening program. It's wonderful that Medicare has agreed to pay for lung cancer screening for people over age 50 with a heavy smoking history. They're looking for lung cancer. I just gave you data that says that if you not only look for lung cancer, you'll find 1 to 2 to 3% lung cancer by screening with that. You'll find 40 to 50% COPD. You'll find 40 to 50% cardiovascular disease. And you'll find 40 to 50% osteoporosis. They need to be treated. And we have a system to find them, because CT is not a standard part of COPD workup. I think it should be. It is where I am, but it's not in the community. It's not. But with the lung cancer screening program paying for it, you're going to have CTs available on these people if you take advantage of it. And it's a way to start moving into this era of treatment, of early diagnosis, discovery, and treatment of COPD. So my bottom line is this. In the long term, this disease is preventable, it is treatable, and someday we're going to cure it. And I want to acknowledge that there's hundreds of investigators across the country. I'm just getting all the press for talking about it. But this is the work of literally hundreds of people from these 21 medical centers, and the support of the NIH, the COPD Foundation, the Fleishman Society, international collaborators, the imaging industry, and the pharmaceutical industry have all put in to make this successful. So, thank you.
Just kind of
Sure.
question. Do you think, based on what you said, which was very impressive, wonderful lecture, Dr. Crapo, do you think that as clinicians we should be finding those smokers that are in their 40s and 50s, have more than the 10-pack years, and instead of doing spirometry, do 6-minute walk tests or respiratory questionnaires to find the ones that are symptomatic and target those for more heavy efforts at smoking cessation? It seems like I remember the U.S. Preventive Services Task Force had recommended not so long ago that spirometry wasn't helpful for asymptomatic smokers, so they didn't recommend it. But maybe, as you pointed out, spirometry is really not very effective anyway for early on, but maybe some of these other tests would be too helpful.
Well, I would agree that spirometry will help you grade their disease. But I just spent a lot of time telling you that the ones that have normal spirometry have a lot of disease. So that's why spirometry doesn't really help you find those. They're going to make you falsely think they don't have disease. What I would do on those is I would send those patients to get a CT under lung cancer screening, so it's paid for. And I would use that CT to look to see if they had airway wall thickening, if they had mosaic pattern, to see if they have emphysema. I would then I would take the medical history. I'd get these. I'd do the CAT score on them. I'd do a dyspnea score on them. I'd take an exercise history. I'm not sure I'd spend time unless you really have a sophisticated, unless you're doing, 6-minute walk is a better research tool. But I would get that history on them, and I would get a history of their comorbidities. I'd look for all those common comorbidities, and I would treat every one of those aggressively. And then I would be sure this person avoided further exposure. And then the last question is what would I do to slow down that inflammation? I'm assuming you got him to stop smoking. To slow down that inflammation, I don't know how to do that. If it were me, I'd probably take 3 or 4 anti-inflammatories out of guess. But I can't argue that's evidence-based medicine. But I think we need to start thinking about the inflammation, and I'm hoping, in fact, I'm working with several drug companies to talk about looking at those patients to see if they can come up with one of their newer anti-inflammatories that really changes the course of the inflammation of this disease. It's not easy, but we can now find them. I can use all those parameters I talked about to pick out a high-risk group and then follow them with often on anti-inflammatory and off of it, looking at outcome over several years and see if there's which one makes a difference. You're 5 years away from that kind of data. Classically, the endpoint people have used has been things like hospitalizations and exacerbations of fallen FEV1, and those are not very robust measurements of the progression. So I think we now can find the patients and we can measure the progression, but we have to do the clinical research to help you answer your final question, was how to best treat that patient. That's as far as I can go, I think.
Excellent presentation. I know you're interested in antioxidants and like that. I was interested, did you look at vitamin D regulatory proteins in the patients, genes for them, or like that? Because vitamin D is very important anti-inflammatory agents, or vitamin E, which if those genes are strong in these patients who are not showing the disease.
And we didn't measure that. I spent most of my career working on antioxidants. So in fact, the reason I started this cohort is because I wanted to know if certain antioxidant enzymes were at-risk enzymes for these patients. We're just now getting the whole genome analysis and the proteomic analysis on this cohort to let us try to answer those questions. But it's taken 10 years to gather all the samples, get the cohort characterized, and it's only as we're speaking that the NIH has actually funded us to do to analyze the whole genome and get the data you're talking about. So I really can't answer the question, but it's at the very center of my heart on this question. I think they're going to be involved, and there's good evidence that deficiencies in antioxidant enzymes, particularly the SOD3, is a factor which increases risk of COPD, and high SOD levels protect against COPD progression. So that's already a part of our genetic findings. But the vitamin D, I can't answer your question yet. But it's a good question, and it should be, because smoking has massive oxidants, and oxidants are part of the inflammatory cascade.
With teenagers choosing e-cigarettes over tobacco now at pretty impressive numbers, what's your best guess for that cohort 50 years from now, if that's their predominant nicotine source?
It will be a big nicotine source. I think that the lung disease is caused by the combustion products.
Yeah.
And so I think that e-cigarettes would if they're used instead of a regular cigarette, would decrease your risk of lung disease. But they'll be a very effective nicotine. And so the question, but there's not much evidence that nicotine drives the disease that I'm talking about. The big evidence is nicotine has a central effect, and it's part of the addictive effect that keeps you smoking. But I haven't seen any evidence that the electronic cigarettes really decrease smoking.
Yeah.
I hope that sometime they would, but I think most of the data is coming out saying that it doesn't really do that. So I don't.
It seems to be the teens' preference now is e-cigarettes over tobacco. Mm-hmm. At least that's what some data is starting to show. So
yeah, and if that holds compared to those who use tobacco, I think they'll have less lung disease and less of the systemic inflammation. But I don't know, because you're switching broad combustion products, which have lots of carcinogens and inflammatory material in it, to a primary nicotine delivery. So it becomes a very different question.
yeah.
There's a lot of reasons why I don't like them, but if I had a choice between that and actual smoking, I'd take that.
So the relationship between osteopenia and COPD, what do we know about it? Is it an epiphenomenon of prior steroid use, disease? Is it vitamin D sort of as a common thing?
Actually, one of our primary investigators with this is Liz Regan, as an orthopedic surgeon, who's been focusing on this issue. And there's not a strong association with steroid use. It's there even in milder disease without history of steroid use. And so we've not been able to relate it to any factor like that. It looks like, I think it's directly related to this systemic inflammatory process. Can I explain it mechanistically? Not more precisely. But I can't find another sort of side reason like steroid use to explain it. And there's more fractures. There's a whole everything you measure with osteopenia and osteoporosis is elevated in COPD. Now I'm talking about COPD versus a smoker with the same amount of without COPD. There seems to be about 30 to 40% of the heavy smokers who develop this progressive inflammatory element, and when you compare them to the smokers of the same degree, they don't. There's a marked difference in both COPD and all the comorbidities. So it appears that there's a genetic propensity of some type that lets about, let's say, 30-40% of the smokers develop a very progressive inflammatory disease that's multisystem.
The conference is about to end.
One more
One
question?
last question. Yes, but you have such a large cohort of patients with active, active or past smoking history. So are you actively looking for the lung cancer, patients who are genetically,
Yes, we screened everybody that came through. Screened. If they had lung cancer, they got referred to their care system. We're finding about this. We have found and are continuing to find lung cancer at about the same rate as was predicted from the lung cancer screening programs. And so we found like 3% when we did our section, and now we're finding a progressive. So we're following that. Our cohort pretty much reproduces the general population that was used to justify Medicare starting to do that screening. And clearly, it demonstrates what I told you already, that the presence of a fallen FEV1 or clear-cut obstruction markedly increases your risk for lung cancer. We're finding that in our cohort as well. Well, thank you very much.